name's Jack Hay. I'm a urology resident in the northwest of England, associated with Manchester Andrology Research Collaborative. Our project is entitled Patient Satisfaction with Penile Prosthesis Insertion Following Radical Pelvic Uro-oncological Therapy. It is well established that radical treatment of pelvic cancers are associated with risk of sexual dysfunction, including erectile dysfunction. For example, in up to 90% of patients undergoing radical prostatectomy may develop this condition. The process is multifactorial and may be, for example, vasogenic or neurogenic from injury to the cavernous nerves. One modality for treating patients with this condition is the use of a penile prosthetic implant to mimic normal erectile function. These patients are typically those who have failed non-surgical interventions. In our study, we wanted to determine the degree of decision regret in patients who have had radical pelvic therapy for urological cancer and then subsequent implantation. So we identified 120 consecutive patients in a single centre who underwent tertiary andrological penile surgery and then surveyed their rates of satisfaction in different modalities. From this group, we identified those who had erectile dysfunction associated with radical pelvic therapy. As you can see in the top left pie chart, 72.2% reported a degree of satisfactory sexual intercourse post-operatively. 45.5% reported at least highly enjoyable sexual intercourse. In the top right, displayed is level of regret, which was reportedly very low, with 81% of patients being at least happy with their outcome. The majority of patients were happy with the overall cosmetic appearance post-operatively, but 18.2% expressed that they were unhappy with the appearance, mainly surrounding penis size. More than half of men were unable to ejaculate after sexual stimulation, but over 27% reported that they did at least mostly. These results show that treatment-resistant erectile dysfunction can be suitably managed with penile prosthetic implants in patients who have undergone radical pelvic therapy for uro-oncological pathology. Most patients will achieve a positive outcome in their symptoms and the ability to have sexual intercourse. Interestingly, a few patients reported that they had not had sexual intercourse but were still reporting being very happy with their results. And we hypothesize that penile prosthetic implants give patients with erectile dysfunction better control over their own bodies and restore self-image. In addition, ability to ejaculate does not appear to affect reported positive outcomes, as 66.7% of men that never ejaculated reported being happy with their outcome. There are some limitations in achieving large sample sizes in a single andrology unit. Patients may be less likely to engage with surveys of a sensitive nature. Furthermore, penile prosthetic implants are performed for a number of different etiologies, and therefore, cancer patients make up only a small subset of the total number, in this case, 11 out of 120. This is best expanded into other centres to gain better insight reflective of a diverse population. However, the results are promising. Finally, more thorough counselling is needed preoperatively to ensure patients are aware that implantation will not increase penile size. We should be making very clear that true size will be reflective of stretched penile length. Thank you very much for listening.